Today's topic is derangement or dysfunction of the electrical activity or function of the heart. In the previous classes, we have discussed the disturbance or disruption of the mechanical function of the heart. But the mechanical function is dependent on the electrical function, that means excitation, and mechanical function means contraction. So excitation contraction coupling is crucial in the total function of the heart. Now, the electrical activity of the heart, derangement of electrical failure means the cardiac arrhythmia. So, this is the electrical failure. Now, outlines of discussion for cardiac arrhythmia. The physiology of cardiac rhythm, then comes the types of arrhythmia and their mechanisms. Then comes the drug treatment for arrhythmias. Now, outlines of discussion related to electrical activity of the heart should be based on the number 1, anatomic substrate, number 2, physiological basis, number 3, abnormal physiology, that is pathophysiology and pathogenesis of arrhythmia, then clinical manifestations, then electrocardiographic correlation, then confirmation of diagnosis, and ultimately or definitely management of cardiac arrhythmia or dysrhythmia. What is the anatomic substrate for genesis of cardiac arrhythmia, or more precisely for genesis of the cardiac electrical impulses? This is the conduction system of the heart. Now, what is the conduction system and what are the components of the conduction system? The conduction system of the heart is a specialized network or circuit of modified cardiac muscle fibers designed for initiation and propagation of electrical impulses through a specialized route containing ACE node, internodal pathways, intra-atrial and interatrial pathways, his bundle branch, right and left. Left again is subdivided into two, anterior superior and posterior inferior. Now, this precise conduction pathway is responsible for maintenance of adequate or optimum cardiac rhythm, efficient cardiac output, and pumping or optimization of pumping essential for pulmonary and systemic circulation, or that means repolarization, ejection of blood. So here is the conversion or translation of electrical activity in the mechanical activity. The first component is a node, second intra-atrial and interatrial pathways, then AV node, then his bundle, then bundle branch, then anterior superior and posterior inferior of the left bundle, then the Purkinje network that embedded in the endocardial surfaces of the heart. So any disruption in this pathway may lead to cardiac arrhythmias or dysrhythmia. This is the sinoatrial node. This is the right atrium. This is the SA node. SA node is situated in the right atrium at the entry point of superior vena cava on the lateral aspect of the wall. It is the natural pacemaker with an intrinsic heart rate of 60 to 100 beats per minute. The next in the hierarchy is the AV node with a rate of about 40 to 60. Then the internodal pathways, the intrinsic rate is 20 to 40 beats per minute. This is the hierarchical fashion of the cardiac conduction system. This is the left atrium, atrioventricular node or AV node. This is the his bundle. This is the right bundle branch, and this is the repolarization. This is the left bundle, left anterior fascicle, left posterior fascicle, and this is the Purkinje network. Is a node already told at the entry point of the superior vena cava in the right atrium on the lateral aspect. This is the basic or primary pacemaker. The intrinsic rate is 60 to 80 beats per minute. Now is a node with interatrial pathways, Wenke-Back, Torel, and Bachman. Bachman goes to the left atrium, and interatrial pathways or intra-atrial pathways produces synchronized contraction of the atrium. That is the atrial contraction. Is a node along with interatrial and intra-atrial pathways for synchronized contraction of the atrium. The pathways are Wenke-Back, Torel, and Bachman. Then comes the AV node. This is the internodal pathways. The arrow indicates internodal pathways. That means electrical connection between the SA node and AV node. This is the only electrical connections between the atrium and the ventricle. Now this is the AV node. Location at the lower end of the interatrial septum in the triangle or at the apex of the triangle of Koch. এক্ষেত্রে একটু স্পেলিং এর সমস্যা হতে পারে, কোনো কোনো ক্ষেত্রে বলা আছে কক্স, কোনো কোনো ক্ষেত্রে বলা আছে কচ। The universal spelling is Koch, K-O-C-H. The angle of Koch is produced by posteriorly coronary sinus ostium, anteriorly the tricuspid septal annulus, and the superiorly a specialized tendon. This is the bundle of his. It has an intrinsic heart rate in the range of 20 to 40 beats per minute. This is the sequence of events of atrial contraction, then ventricular contraction. The synchronized atrial and ventricular contraction maintains normal rhythm, efficient cardiac output, and optimized pumping essential for systemic and pulmonary circulation, and this is crucial for the mechanical performance of the heart. So impulse AZ node, internodal pathways to AV node, then the bundle of His, then through the right bundle, left posterior inferior and anterior superior. This is the Purkinje network. This is the initiation and propagation from the AZ node. বাকিটা আগেই বলা হয়ে গেছে। Now anatomic or mechanical point of view, right atrium, right ventricle, left atrium, left ventricle. The synchronized and harmonized contraction of atrium and ventricle is responsible for ejection of blood into the pulmonary artery as well as into the aorta. This is the pulmonic circulation, this is the aortic circulation or systemic circulation. Now conduction system of the heart. This is a 3D model. Initiation of impulse, transmission, activation of the left ventricle, synchronized activation of the left ventricle leads to synchronized activation of the left and right ventricle. That means synchronized activity of the atrium, then synchronized activity of the ventricle, then both harmonized for mechanical performance of the heart. This is the 3D model of cardiac conduction system. Now, the physiologic basis of electrical impulse. Our electrical impulse is voltage dependent. The cell is negatively charged at rest, and the action potential or transmembrane action potential is responsible for genesis of electrical impulse. It has got 4 phases: phase 0 to phase 1, phase 2, phase 3, and phase 4. Phase 4 means the action potential or transcellular voltage is about minus 90 millivolt. Then there is opening of the sodium channel and influx of intracellular sodium produces rapid depolarization. This is the phase 0. Phase 1, transient opening of the potassium channel produces or have a tendency to revert the transpotential or transmembranous potential to a 0. This is the potassium channel. Transient potassium channel opens and potassium efflux produces a reduction in the depolarization and a notch. This is the phase 1 and initiation of the repolarization. Then comes the stage or phase 2. That means calcium channel opens and influx of calcium with balanced delayed rectifier potassium channel produces the stage or phase 3. This is the potassium efflux, stage 2. This is the potassium efflux and calcium influx. So stage 2, influx of calcium along with balanced delayed rectifier potassium efflux produces phase 3. Then comes the phase 2. Then comes the stoppage or closure of the calcium channel and delayed rectifier potassium channels open that lead to efflux of potassium again producing or reducing the action potential to the phase 4. This is the phase at the rest अर्थात resting transmembrane potential. So the membrane potential has got 4 phases. Phase 4, that is phase at rest. Then phase 1, depolarization, sodium influx. Phase 0, phase 1, potassium efflux. Phase 2, calcium influx, potassium efflux. Stage 3, calcium closure, potassium efflux, and this is the stage 4. This is the summary and the consequences. Essay note, atrial activation, right atrium, left atrium. This is the action potential of the atrial essay note. This is the atrial muscle action potential. The relationship P wave is the atrial depolarization. This is the P wave. PR interval means onset of the P wave and onset of the QRS complex. The total duration is the PR interval. And the QRS complex, this is the ventricular depolarization, that is phase 0 to some extent phase 1. And this is the T wave related to ventricular depolarization, that is phase 3 or 4. This is the electrocardiographic correlation with the cardiac transmembrane action potential. P wave, atrial depolarization, perinterval, onset of P and onset of the QRS complex. QR is ventricular depolarization, T wave, ventricular repolarization, and U wave, again ventricular repolarization. This is the total summary of the physiologic basis of electrical impulse. This is the conduction pathway. This is the electrocardiographic correlation. This is the activation. So, এক্ষেত্রে anatomic and physiologic দুটো জিনিস clearly correlated বা interrelated দেখা যাচ্ছে। এক্ষেত্রেই তৈরি হচ্ছে electrical impulse or electrical activity. The inscription in the electrocardiograph is the ECG. That means P, QRS, ST, and T wave, and lastly U wave. Now the definition of the cardiac arrhythmia: an abnormality in the cardiac rhythm is known as arrhythmia. Cardiac arrhythmia may result from initiation or generation of the electrical impulse and or propagation of the electrical impulse through the conduction system. Types of arrhythmias: arrhythmia may be bradyarrhythmia or tachyarrhythmia. Bradyarrhythmia definition: heart rate less than 60 beats per minute during day or 50 beats per minute at night, and tachyarrhythmia means heart rate exceeding 100 beats per minute. Again, the tachyarrhythmia can be subdivided into two: supraventricular tachyarrhythmia and ventricular tachyarrhythmia. At or above the level of AV node and AV junction, this is the supraventricular tachyarrhythmia, and below the AV junction or AV node, this is the ventricular tachyarrhythmia. অন্যভাবে বলা যেতে পারে suprahis tachyarrhythmia or infrahis tachyarrhythmia. আরও precisely বলতে গেলে AV junction and suprahis tachycardia or tachyarrhythmia, that is the supraventricular, and AV below the AV junction or infrahis, this is the ventricular tachyarrhythmia. Now, refractory period. আমরা দুটো ভাগে ভাগ করি: absolute refractory period, then relative refractory period. What is absolute refractory period? A stimulus, irrespective of its strength, cannot stimulate cardiac fibers. An electrical impulse, irrespective of its strength, can't stimulate the cardiac fibers. The time period corresponds with the depolarization and the early part of repolarization. This is the absolute refractory period. No strength of electrical stimulus or electrical stimulus of irrespective of its strength can't excite or stimulate the cardiac fibers. It is relative refractory period. During the later part of the repolarization, an electrical impulse stronger than the normal can stimulate the cardiac fibers. This is the relative refractory period. And the absolute refractory period plus relative refractory period constitute the effective refractory period. So, absolute refractory period, no strength of electrical stimulus. Relative refractory period, that means electrical stimulus stronger than the normal, and absolute refractory period or relative refractory period summation হচ্ছে effective refractory period. Electrocardiogram, that means the surface detection of cardiac electrical activity through placement of the leads. Surface detection of electrical activity through the placement of leads over the chest wall, not directly over the heart. That has got several components: P wave, atrial depolarization, peer interval, onset of P, and the onset of the QRS complex. This is the R wave. This is the initial negative deflection before R. This is the Q. This is the S wave. That is the negative deflection or inscription following the height of the R is S. Then comes the T wave and the T and S wave. This is the ST segment. And this is the QT interval, onset of Q waves and the termination of the T wave. This is the QT interval. So P, peer interval, Q, QRS or S, then T and ST segment. Surface detection of or surface recording of cardiac electrical activity through placement of leads over the chest wall. Phase 0 or 1, QRS complex. Phase 2, ST segment. Phase 3, T wave. Phase 4, resting membrane potential. So phase 0 and to some extent 1, this is the QRS, phase 2 depolarization, that is the ST, phase 2 কি ছিল? Calcium influx and delayed rectifier potassium efflux. This is the phase 2. And phase 3, calcium channel closed but delayed rectifier potassium channel opens. So phase 0 to 1 QRS, 2 ST segment, phase 3 T-wave. অলরেডি বলা হয়েছে এরিথমিয়াকে আমরা দুটো ভাগে ভাগ করি, ব্র্যাডি এরিথমিয়া অ্যান্ড ট্যাকিরিথমিয়া। ব্র্যাডি 60 ডিউরিং ডে টাইম or less than 50 and tachyarrhythmia more than 100 beats per minute. Now, before going to discussion of the classical arrhythmias, I would highlight arrhythmia. There is misnomer. It is not arrhythmia. It is a normal physiological phenomenon. A said node is under the influence of the autonomic nervous system, that is, by the parasympathetic tone and by the sympathetic tone. Fluctuation in the parasympathetic tone produces a phasic variation in the heart rate in response or related to respiration. In inspiration, parasympathetic tone or vagal tone is suppressed, producing an increase in heart rate. But in expiration, there is a reduction in heart rate. The phasic variation in heart rate with respiration is known as sinus arrhythmia. This is quietly normal, usually present in the young adult. It is virtually not an arrhythmia. This is an example of the sinus arrhythmia. P configuration normal, QRST segment normal, but this is the shorter compared to that one, and this is totally related to the respiration. This is with expiration and this is with inspiration. No change in the configuration of the P or QRS or T, only the change in the rate and relationship with the respiration. Now today's arrhythmia is brady arrhythmia. তার আগে বলে রাখা ভালো যে এরিথমিয়ার প্যাথোফিজিওলজিক বেসিস বা প্যাথোজেনেসিস। Number 1, alteration in the automaticity or enhanced automaticity. Number 2, triggered activity. Number 3, re-entry phenomenon. Automaticity, triggered activity and re-entry phenomenon should be discussed before initiation of the lecture related to tachyarrhythmia. Today I want to discuss the bradyarrhythmia. Here, initiation of impulse formation and nerve propagation is responsible for bradyarrhythmia. Now, the most common is sinus bradyarrhythmia, a slow atrial rate that can occur at rest or as a chronotropic response. This is the sinus bradycardia. Heart rate is less than 60 beats per minute. Sinus bradycardia may be physiological and reversible, or sinus bradycardia may be pathological. Now, sinus bradycardia বলতে গিয়ে কিছু এক্সট্রিনসিক ফ্যাক্টরসের কথা বলা উচিত যেগুলো রিভার্সিবল, তারপরে থাকছে ইন্ট্রিনসিক ডিজিজেস অফ দ্য সাইনাস নোড অর অ্যাট্রিয়াল মায়োকার্ডিয়াম, যেগুলো ভার্চুয়ালি ইরিভার্সিবল। রিভার্সিবল ইটিওলজির মধ্যে থাকছে আমাদের নাম্বার ওয়ান, medical conditions like hypothyroidism, hypothermia, sleep apnea, hypoxemia, antihypertensive medication তার মধ্যে থাকছে বিটা ব্লকার, প্রোপাফেনন, ফ্লেকেনাইট এটসেট্রা। থাকছে অ্যান্টি এরিথমিক মেডিকেশনস, তার মধ্যে থাকবে সোটালল, থাকছে অ্যান্টিসাইকেট্রিক মেডিকেশন, সিলেক্টিভ সেরোটোনিন রিআপটেক ইনহিবিটর, phenothiazines, etc. and others, that is the anesthetic agent like propofol. So medical conditions, antihypertensive medications, then anti-arrhythmic medications, then anesthetic agents. These are the factors responsible for reversible sinus bradycardia. Therapy is correction of the reversibility. The assessment of bradycardia should focus on number one, confirmation of the reversible influences. Second, confirmation of the sinus node dysfunction. And third, the imaging or cardiac imaging if structural heart disease is suspected. একটা কথা ইচ্ছা করে এড়িয়ে যাওয়া হচ্ছে, দিস দ্য নিউরালি মিডিয়েটেড সিনড্রোমস। দিস ইজ অলসো রিভার্সিবল। মেডিকেল কন্ডিশন, অ্যান্টিহাইপারটেনসিভ মেডিকেশন, অ্যান্টি-এরিথমিক মেডিকেশন অ্যান্ড অ্যানেস্থেটিক এজেন্টস, তার সঙ্গে নিউরালি মিডিয়েটেড syndrome produces bradycardia and reflex vasodilatation or both. Example, carotid sinus hypersensitivity. Second, neurocardiogenic syncope or vasovagal attacks. Now, sick sinus syndrome or sinus node dysfunction caused by idiopathic fibrosis of the sinus node. Other causes of fibrosis include ischemic cardiomyopathy, infiltrative cardiomyopathy, and myocarditis, or very rare conditions like amyloidosis. So, sick sinus syndrome, an intrinsic disease of the sinus node produced by fibrosis, infiltrative cardiomyopathy, ischemic heart disease, dilated cardiomyopathy, or myocarditis. What are the features of sinus node dysfunction? Again, features can be subcategorized: initiation of impulse formation and propagation or conduction of impulse formation. Now, sinus node dysfunction is reflected as sinus bradycardia, sinus exit block, first degree, second degree, third degree, sinus arrest, brady-tachy syndrome, and lastly, chronotropic incompetence. Chronotropic incompetence. So, sinus bradycardia, sinus exit block, sinus arrest, exit block, first degree, second degree, third degree, sinus arrest, and lastly, brady-tachy syndrome. কোনো ক্ষেত্রে chronotropic incompetence এর কথা বলা হয়। এটা ক্লিয়ার করে নিই। What is chronotropic incompetence? Inability of the SN node to discharge normally in response to physiological load or activity or demand. Inability of the sinus node to discharge efficiently in response to increased physiologic activity, demand, or both. This is the chronotropic incompetence that may warrant implantation of cardiac pacemaker in severe situations. Then comes the AV block, first degree, second degree. Second degree is again movie step 1, movie step 2, and fixed 2:1 AV block. Then comes the third degree AV block that may be suprahis or infrahis and is recognized by the duration of the QRS complex on the surface ECG. Now, sinus exit block. The electrophysiological phenomenon of sinus node firing or discharge with delay or interruption of conduction. Delay or interruption of conduction. First degree AV block means delay in initiation or formation of SA node discharge. A first degree SA block cannot be recognized on the surface ECG. Second degree SA block, again type 1 and type 2. That is progressive delay followed by intermittent failure. Progressive delay followed by intermittent failure, recognized by gradually shortening PP interval followed by absence of the P wave. Second degree SA block, there is a fixed delay with sudden unexpected interruption or absence of the P wave. This is the second degree SA block, movie step 2 block. And high degree or SA exit block, absence of multiple P waves. This is the third degree AV block. এক্ষেত্রে ডিফারেন্সিয়েশনের রাস্তা হচ্ছে যে pause or the interval not encompassing P wave is a multiple of the normal PP interval. That means 2:1 or 3:1. This is the third degree AV block. And what is sinus arrest? Sinus arrest means sudden or unexpected absence of P wave due to non-generation of electrical impulses from the SA node. So exit block means delay or interruption of conduction, or sinus arrest means no generation or genesis of atrial electrical impulses. Here, the interval not encompassing the P wave is not a multiple of the normal PP interval. Now the electrocardiographic examples. Grade 2, type 1. This is the PP interval. This is the PP interval. That one sorting. Grade 2 type, PP interval, that's absence of the P name, gap project. This is a third degree, normal, then total absence of the P. And this PP interval is the more than the normal PP interval. This is the fixed delay, then interruption. So this PP interval is twice the PP interval. তোমরা দেখো এই পিপিটাকে যোগ করো এই পিপির সঙ্গে সমান, তার মানে যেটা ফিক্সড ডিলে ঘটেছে, যেটা চোখে পড়ছে না, তারপর একটা পি পাচ্ছি না, এবং পি না পাওয়ার ফলে এই যে পিপি ইন্টারভ্যাল তৈরি হচ্ছে, এই পি, দিস ইজ দ্য টুয়াইস দ্য নর্মাল পিপি। গ্রেড 1-এ তোমরা লক্ষ্য করে দেখো gradual shortening of the PP বলেছি। This is the P, this is the P, this is the P, this is the P, this is the PP interval, this is the shortening of the PP interval. Then there is absence of the P. And third degree কি বলেছিলাম? Unexpected drop. And this is the PP interval. This is a multiple of this PP interval. This is a sinus arrest. The absence of the P total assistant features. And this interval is not a multiple of the normal PP interval. Now summarizing the 6 sinus syndrome. Number 1, sinus arrest. Number 2, sinus exit block. Number 3, tachybrady syndrome. Number 4, chronotropic incompetence. Now what is tachybrady syndrome? An episode or runs of tachyarrhythmia followed by alternating bradyarrhythmia or upset pause. Tachybrady syndrome are runs of tachyarrhythmia followed by alternating bradyarrhythmia or upset pause. This is tachybrady syndrome. এক্ষেত্রে একটি পয়েন্ট খুব লক্ষণীয় যে ট্যাকিব্র্যাডি সিনড্রোমে অ্যান্টি এরিথমিক ড্রাগস ফর সাপ্রেশন অফ দ্য ট্যাকিকার্ডিয়া করা হয় দ্যাট মে এক্সারবেট দ্য symptoms of bradyarrhythmia. So here pacemaker implantation is mandatory. Repeating the components of the sinus node dysfunction: sinus arrest, sinus exit block, type 1, type 2, 2A that is Wenckebach, 2B that is Mobius, type 3 that is complete, then tachybrady syndrome, then chronotropic incompetence, then this is the initiation, then and propagation, then only propagation, that is the AV block. Again, type 1, type 2, type 2, 1, that is the Wenckebach, then Mobius, then fixed twist to 1 epiblock, then third degree epiblock. 6 sinus syndrome. Symptomatic 6 sinus syndrome management is pacemaker, that is the permanent pacemaker. So indication of pacemaker therapy in 6 sinus syndrome. Symptoms attributable to sinus bradycardia. Number 2, sinus bradycardia by means of antiarrhythmic or medication, that is crucially essential but having no alternative. লাইনটা আরো সহজ বাংলায় বলার চেষ্টা করছি যে অ্যান্টিআরথমিক থেরাপি বা মেডিকেশন থেরাপি যেটা আমার খুব এসেনশিয়াল, যার কোনো বিকল্প নেই, তা সত্ত্বেও পেশেন্টের সিভিয়ার সিমটোমেটিক সাইনাস ব্র্যাডিকার্ডিয়া হচ্ছে, সেক্ষেত্রে পেসমেকার অবশ্যই লাগবে। ফার্স্ট হচ্ছে সিমটোমেটিক সাইনাস ব্র্যাডিকার্ডিয়া, সেকেন্ড হচ্ছে সিভিয়ার সিমটোমেটিক সাইনাস ব্র্যাডিকার্ডিয়া বাই ড্রাগস or medications essential for the disease but without no alternative agent. Third point, tachybrady syndrome. And fourth, chronotropic incompetence. If severe symptoms is attributable to the sinus bradyarrhythmia. What are the symptoms of sinus bradyarrhythmia? That is exercise intolerance, fatigability or weakness, syncopal attack or pre-syncopal attack, dizziness, as well as exacerbation of the heart failure or cardiac mechanical functions. These are the symptoms of cardiac blood arrhythmias, and management choices pacemaker implantation, that is classically dual chamber pacemaker with dual function. That means triple D. First D for dual sensing, that means sensing the dual chamber. A second D for dual fishing. And third, dual mode of action, that means mode of excitation as well as mode of inhibition. And again, this is modified the pacemaker DDR, that means dual chamber sensing, dual chamber pacing, dual mode of action, and related to the rate or body metabolic processes, triple DR, DDDR. This is the classical management of sinus bradyarrhythmia related to the sick sinus syndrome, and that must be symptomatic in its nature. AB block, again, type 1. Here there is no block, this is delay deflected by prolongation of the peri-interval exceeding 200 milliseconds or 0.2 seconds. This is the first degree AB block. ECG manifestations each prolongation of the peri-interval. Second degree AB block, moving step 1. Progressive prolongation of the peri-interval followed by drop of conduction. Then the movie is type 2, fixed peri-interval. যেখানে বলা হয়েছিল এসএ ব্লকের ক্ষেত্রে fixed delay followed by loss of conduction, usually associated with widening of the QRS complex, because movie step 2 is usually infra-his pathology. Then the third degree AB block, complete interruption of conduction over the conduction system. Now the electrocardiographic manifestations. Grade 1. This is the peri-interval. And the peri-interval is prolonged, more than 200 milliseconds or more than 2 seconds. This is the grade 2 type 1. Peri-interval, prolongation of the peri-interval, again prolongation of the peri-interval, or prolongation of the peri-interval, then P not conducted. Peri-interval, prolonged, drop. This is the type 1. Type 2. This is the fixed PR fixed, then PR drop. PR fixed, PR drop. This is the 2. Grade 3, P absent. Here is the rate, it's slow, number 1, regular, number 2, and presence of AV dissociation. Third degree AV block means complete heart block is characterized by number 1, slow ventricular rate, usually less than 40. Number 2, regular rate. Number 3, presence of AV dissociation. What are the causes of AV dissociation? AV dissociation can be produced by sinus default, by third degree or complete heart block, by usurpation, that means junctional or ventricular tachyarrhythmia. So AV dissociation is caused by sinus default, usurpation like junctional or ventricular tachyarrhythmia, and lastly complete heart block. How do you diagnose a complete heart block on the clinical basis or at the bedside? Low ventricular rate, regular in character, wide pulse pressure, presence of the intermittent cannon A waves, and variable intensity of S1. That's all. শুধু একটাই প্রশ্ন যে কমপ্লিট হার্ট ব্লক কি অলওয়েজ রেগুলার? কমপ্লিট হার্ট ব্লক ইজ অলওয়েজ রেগুলার except two situations. One is supernormal conduction and the second is ventricular phasic sinus arrhythmia. Supernormal conduction যদি থাকে বা ventricular phasic sinus arrhythmia থাকে, complete heart blockage rate may be irregular. কিভাবে আমরা ক্লিনিক্যালি ডায়াগনোসিস করব 2:1 AB block or second degree AB block? Third degree AB block, slow ventricular rate, wide pulse pressure, intermittent cannon, but that is not reflected in the radial pulsation. এখানে দুটো এ পাচ্ছি, এখানে একটা পালস পাচ্ছি, সহজ হিসাব 2:1 AB block. সুতরাং aberration from normalcy of heart rate, second হচ্ছে discrepancy between the A waves and the radial arterial pulse. This is a clinical clue for the diagnosis of second degree, especially 2:1 AB block. And there is also apex beat to radial beat ratio disruption. First degree AB block, নতুন করে দেখানোর কিছু নেই. Prolongation of the P, prolongation of the P. This is the complete heart block, fixed per interval. This is the second degree, MBBS type 2. Management, symptomatic AB block, disabling AB block, general management, permanent pacemaker implantation, especially triple DR, or in a situation of temporary or chances of reversibility, temporary pacing, as well as correction of the underlying cause. আজ এই পর্যন্ত কিছু বাদ দিয়েছি, সেগুলো একটু মনে করার চেষ্টা করছি. বল না কি বাদ দিয়েছি? আচ্ছা, এটা দেখে কি মনে হচ্ছে? 2:1. এটাও তো তাই মনে হচ্ছে না? আরো বড় দরকার ছিল. আমি যে এসিজিটা এনেছি এটা ছোট থাকতে গেছে, তবে খুব ভ্যালিড রেশনাল কোশ্চেন করেছে. এই ছোট কমপ্লেক্স থাকলে এটা বোঝা খুব মুশকিল, এক্ষেত্রে দেখানো যায়নি. 2:1 AB ব্লকে যদিও MBBS টাইপ 2-তে রাখা যায়, কিন্তু আলাদা করে রাখাটাই বাঞ্ছনীয়. আর কারো কিছু? আমি পরে এটা মনে থাকবে, ইসিজি পেলে আমি পরে একটা দেখিয়ে দেব যে ক্লাসিক্যাল MBBS টাইপ 2 মনে থাকবে, এটা মনে থাকবে. আর কারো কিছু? তাহলে বুঝতে পারছিস সব ভুলটাই কি ইচ্ছাকৃত আর সব ভুলটাই কি অনিচ্ছাকৃত? তাহলে দ্য মেসেজ ইজ, ক্লাসে কখনো কখনো ভুল বলতে হয়, 100% ঠিক বললে কিন্তু ক্লাস হয় না, কোনো কোশ্চেনই আসবে না. তো এটা হচ্ছে ভুল করে সাফাই গাওয়ার একটা নতুন টেকনিক. আজকে যদি নবরূপ না থাকতো এই ভুলটা ধরাই পড়তো না, আগের দিনে ঠিক তাই. ঠিক আছে.